Okay, why don't we start? I'm George Bosse. I probably met a lot of you. I've been doing these talks here for a number of years. My other training was in medical toxicology, and I'm medical director of the Poison Center, which is, if you're not familiar with it, it's a few blocks down the road. It's actually part of Norton's. But I'm going to talk about acetaminophen. Acetaminophen, I think, is important, even though for us in the Poison Center business, it seems to be bread and butter. It seems like every few months there's some acetaminophen case that's peculiar and it doesn't fit the usual sort of picture. And aspirin, I think aspirin's important because, especially from the physician standpoint, there are a number of reasons you can get burned with cases that have aspirin toxicity, and I'll go over those points with you. Now, there's a handout that everybody should have, or two handouts rather. Acetaminophen was discovered a long time ago in the late 1800s. Like many drugs, it took a while to come to market. I forget when it came to market. I think it was in the 1960s. And of course, the nice thing when it came out is that it has fewer side effects compared to aspirin when you use it in therapeutic doses. But like every drug, every chemical that's out there, it has toxicity. And the first cases of hepatic necrosis were discovered or were found in the late 1960s. As far as some of its kinetics, in therapeutic doses, peak absorption is fairly rapid. If you take 650 milligrams or a gram of acetaminophen, you should probably have peak levels in about 30 minutes, 45 minutes, something like that. But in overdose, that's a different situation. In overdose, you probably are not going to get peak levels till about 4 hours out, and that's why when you use the nomogram, if you ever used it, and it's at the end of the handout, the nomogram, when you plot your levels versus time, things don't start until 4 hours post-ingestion. And this is a common scenario with many drugs and pills in overdose. We always have the saying that pharmacokinetics are not the same as toxicokinetics. So here's just one of many examples where peak absorption with therapeutic doses is fairly rapid, but with overdose it takes several hours to get peak levels. And the same thing can happen with elimination too. And the same thing will happen when we talk about aspirin. Metabolism of acetaminophen goes by three main routes. Two lead to relatively benign byproducts. That's via glucuronidation and sulfation. There's always a small percentage that is metabolized to a toxic compound that is abbreviated NAPQI. We just call it NAPQI. And NAPQI is the compound that normally, if you take normal doses of acetaminophen, it's detoxified by endogenous glutathione. However, if you take too much acetaminophen, you form too much NAPQI, you run out of your glutathione stores, and the NAPQI can bind to liver cells, and then that's where the trouble starts. The half-life of acetaminophen is normally about 2 to 3 hours. In overdose, this goes up. Again, another example of toxicokinetics are not the same as pharmacokinetics. In overdose, you might expect the half-life to be somewhere in the range of 4 hours. In the past, we used to in some patients get serial levels of acetaminophen, trying to see if their half-life is prolonged and then trying to figure out if they're toxic based on that. But we've really gotten out of doing that. There's a lot of problems with that, and in essence we never tried doing serial levels to calculate half-life anymore. As far as its pathology, it's mainly going to affect the liver. However, in some cases you will see renal toxicity. In a lot of cases of renal toxicity, it's essentially going to be a case of a hepatorenal type syndrome, so you're going to see both. But you can also see just renal toxicity alone, although it's not very common. And it would be very rare, but there are some reported cases of myocardial and pancreatic damage. As far as what you see clinically, in the first 24 hours or so, you may see no symptoms, which can really be a problem for you as a physician, because if an overdose patient comes in and they're a poor historian, which is often the case, and they look good, and they have no symptoms and they have nothing on exam, you might be fooled because they actually may have taken a toxic dose of acetaminophen. Or sometimes they will have some GI symptoms like nausea, vomiting, some mild belly pain. But there too, GI symptoms are so obviously nonspecific for various toxins and various other medical conditions. So just be aware that there may not be that much going on in the first few hours. With acetaminophen, it's very, very unusual to have someone with depressed mental status or metabolic acidosis. However, in very rare cases with extremely large overdoses, it can occur. And I think the last case I remember from University Hospital is probably about 2 or 3 years ago, where someone had a level, acetaminophen level somewhere in the 500 and something range, micrograms per ml, and they had mental status depression and metabolic acidosis. But as a general rule, that does not occur. After the first 24 hours, if someone's really taken a significant dose of acetaminophen, the first thing that's going to happen, if you measure their LFTs, about 24 hours, you're going to see rises in their transaminases, so their AST and ALT. Although the reality is if they really took a large dose, you may see those rises in transaminases about 12 to 18 hours out. And then, as you can imagine, as time goes on, say 48 hours out or 3 days out or something like that, then you may see signs on exam of obvious liver failure with jaundice, encephalopathy, and that sort of thing. Then what happens after that? If they've developed hepatic toxicity, really one of three things is going to happen. Either they're going to recover, they're going to die, or they're going to get a liver transplant. I have on the slide here chronic long-term hepatic sequelae is unusual. I should probably change that to essentially unheard of. This is not like hepatitis B or hepatitis C where someone walks around with chronic liver function abnormalities for months or years. It's, again, they're either going to die, recover, or get a liver transplant. Children, for whatever reason, are less prone to toxicity. By children, I mean roughly under the age of 8 or 10 years old. And at the Poison Center, we actually have different referral threshold doses, milligram per kilogram doses for kids under the age of, actually I think we use under 6 years of age. And it's a little bit unclear why kids are less prone to toxicity. It's theorized they somehow metabolize things a little bit differently. Diagnosis. Of course, first of all, you've got to suspect it. And then if you suspect it, you want to get an acetaminophen level. And ideally, in an acute single overdose type of scenario, you want to get your acetaminophen level at 4 hours or more post-ingestion. But many of you have been in the ER. You know how it goes when someone comes in. It's, you know, whether they're 2 hours out or an hour or 5 hours out, they all get this battery of labs, whether they need it or not. And invariably, someone might have an acetaminophen level that's drawn at, say, 1 hour and 57 minutes. But in terms of you deciding whether or not you really need to treat them based on the nomogram, you really want to get a level at 4 hours or more post-ingestion. And assuming you have a level that's 4 hours or more post-ingestion, there's really no need to get a repeat level. It's going to go down. It's going to go down to 0 at some point as long as the patient is alive. But like I said earlier, we don't do the half-life calculations anymore. So once you've gotten that level 4 hours or more post-ingestion, you've got to make a decision whether or not you're going to treat them. The nomogram. Let's look at the nomogram. It's on the last page of the handout. The first thing I'll say about the nomogram is someone once wrote an article not too long ago looking at nomograms in various books and articles, and apparently there's a high rate of nomogram errors in various sources. I can't name those sources. I'm hoping and thinking that the nomogram I have for you is correct. But if you look at the nomogram, I think the nomogram is problematic if you're a physician who does not treat acetaminophen ingestion all that often. Certainly in internal medicine, and for those of you who are med peds, you're going to see a fair number of cases. But some of the things that I think are confusing for the APAP novice, so to speak. First of all, in this nomogram, when you look at the y-axis, there's two different lines with two different levels, and I don't know why they do that. For all intents and purposes in the United States, we use the measurements of micrograms per ml. The other line is listed in micromoles per liter. We never really use that in the United States, so that should just be dropped out. The other thing is when you look at the nomogram, in the center there are two lines, and I wish they would just cut those out and always put one. The darker upper line is the initial line that was developed back in the, I think it was early 70s by a guy named Barry Rumack. And that's the line where they say that if you plot someone's level and it's on that line or above, it's, I think the term is probable hepatic toxicity, so they may develop hepatic toxicity. But what happened is, at least in the United States, people thought, well, instead of using that as a treatment line, let's lower that line sort of for a margin of error type of thing. So the lower dotted line is really the line that we use to determine whether or not someone needs to be treated here in the United States. My understanding is in Great Britain they still use that upper dark line, but I also have seen case reports where in Great Britain they have more treatment failures. So I think that the lower line is a little bit safer in terms of using that. And when you look at the numbers, it essentially lowers things by about 25%, so to speak. For example, if you use the upper line at 4 hours, the level to treat would be 200 micrograms per ml. However, the lower line, which is the one we use, the level at 4 hours there is 150 micrograms per ml. And as you notice, the nomogram only goes to 24 hours post-ingestion. And I'll talk a little bit more about what you do after that. But in any case, one question I'll get is, well, we've plotted this time versus level, and it's just barely below the line, or just barely above the line, or on the line. What do we do? And I usually just say, well, if you think it's on the line or above, and you think the history is reasonably accurate, go with it. If it's below the line, and if you think the history is reasonably accurate, go with it. I mean, at some point you got to decide what you're going to do, and that's what I usually do. The other thing that you'll notice is when you look at the level to treat, say at 24 hours or 22 hours out, it's not very high. So, for example, at 24 hours out, I think the treatment level is something like 4.5 micrograms per ml. So that brings up the point. Someone might say, well, gee, we got an acetaminophen level on a patient, and it's, they're a poor historian, and we don't really know what they did. And it's not very high. It's only 8.9 micrograms per ml. I think we'll just bag it and not treat them. Well, just remember, that may be significant, especially if they've been, say, 23, 24 hours out, something like that. So that's another thing I'll mention about the nomogram. Acetaminophen is a toxic time bomb. I always say that with most, but not all toxins, but with most toxins, if someone's going to get signs and symptoms, it's usually in the sort of ER time frame of 4 to 6 hours, somewhere in that range. However, there's a list of about, 20 or probably more toxins. Some are very unusual, but some are very common, like acetaminophen, where things may not develop till, say, 12 hours out, 24 hours out, something like that. And I've actually got a separate talk on that and wrote an article on it once if you ever want to hear it. But it is a toxic time bomb. So just remember, if you have someone that come in, even if they're a poor historian, but if you think they overdosed and maybe they have some GI symptoms, maybe they have no symptoms, you would hate to miss acetaminophen toxicity. It's so easy to get a level, even in smaller hospitals in the United States. The antidote works so well. Just beware early on. You would hate to miss acetaminophen, and it's something you can really test for quite easily. Therapy, the main therapy that we use in the United States is N-acetylcysteine, or as we say, NAC. The trade name is Mucomyst. Mucomyst or NAC, I don't think anybody is really sure exactly how it works. The best explanation I've heard is it may work somehow as a glutathione substitute. As far as how well it works in terms of the time post-ingestion, it works well probably within the first 8 hours or so post-ingestion. After 8 hours or 8 to 24 hours, it still works pretty well, but the clock is really ticking after 8 hours or so. And this brings up the point, too, that if you have someone that comes in within the first 8 hours, and let's say they come in at, 3 hours out, and you think, well, sounds like they took a fair amount. What's a fair amount? Well, as a rough guide, in adults we say greater than 10 grams is likely to be toxic. In a kid, we'd say greater than 150 milligrams per kilogram is likely to be toxic. And let's say they come in and they say, I took 11 grams. On one hand, you might say, gee, I believe their history, I'm really suspicious. I'm going to go ahead and fire up the Mucomyst and get them started. But another approach you can take is you could, you're 3 hours out, you could wait till a 4-hour time mark, you'd get the level, realize that the lab won't come back till about 5 or 6 hours out, but as long as you get your treatment started within the 8-hour window, it probably really doesn't matter whether you do it at hour 1 or hour 7 or something like that. However, if someone comes in at, say, hour 9, a little bit late, and they say they took 15 grams, you might want to treat them empirically, get your level, and then you can stop it if it turns out to be below the treatment line. Now, intravenous NAC is something that came out in 2004 here in the United States. That's when it received FDA approval. It's been used for many, many years prior to that in Canada and essentially all the European countries. And does anybody know what halted things? What's the main thing people were worried about? Yeah, anaphylactoid type of reactions. With oral Mucomyst, it would be very, very unusual to have an anaphylactoid type of reaction, but with IV N-acetylcysteine, it does happen in a certain percentage of patients. And Fortunately, since it's come out, I mean, I've seen a few in our ER here, but they were not serious. I was kind of worried when it first came out that we'd be hearing all these case reports around the country of people who died from severe anaphylaxis with wheezing and respiratory distress and hypotension and that sort of thing. But it's really sort of taken a hold. And I put down here 20-hour protocol. I should really say 21-hour protocol, but it's essentially 1 day in the hospital. And that's in comparison to the old oral NAC preparation, which the usual protocol there was you had to do a 72-hour course, which meant 3 days. And as you might imagine, this newer product, which goes under the trade name Acetaminophen, is quite a bit more expensive than the oral preparation. But yet when you factor in the hospital costs of 1 day versus 3 day, from an expense standpoint, it's a lot cheaper to do the 1 day course. And it's certainly much more convenient to do it through IV than PO. I'm not sure that's really more effective than someone who's late. It would probably, probably just from the standpoint of effectiveness, it'd probably be just the same as someone who's 9, 16 hours out, treating them IV versus PO. PO NAC, I used to have several slides on this. I don't say much about it anymore, although there are a few situations where I would use it. The dose, I'm not going to mention. What's the main side effect of PO NAC? A lot of you are already too young to remember. It tastes and smells terrible. It has a sulfur-like smell, and vomiting is a big problem. There are a lot of different tricks you can do if you really want to use this to try and get the stuff down, but it is very emetogenic, so to speak, if there's such a term. Now, I was mainly talking, when you talk about the nomogram, I was talking about acute, what we call acute single ingestion. So in other words, someone takes one bolus of pills at one time. But another thing that happens with acetaminophen or any drug that's out there is chronic ingestion. So someone takes a certain number of pills this morning, they took some yesterday, they took some the day before. What do you do there? And this is probably when this happens, this is probably the most common call that I get from our nurses at the Poison Center. And unfortunately, you can't use the nomogram for this. So it's really a judgment call in terms of whether or not you're going to treat them. And in general, what you do is you take into account three things. First of all, you get their acetaminophen level. You look at their LFTs, particularly the transaminases, to see if they're elevated, and you see if they have GI symptoms or not. And then you sort of put it in the stew and decide whether or not you should treat them. And in general, we tend to err on the side of treatment since the treatment is fairly benign, although it does put the patient in the hospital. But there's really no hard and fast rules here, but we do tend to err on the side of treatment. Now, one scenario that sometimes comes up, we talked about how Mucomyst somehow may act as a glutathione substitute. Well, one thing that commonly happens is we'll have someone who's many hours to days out where their acetaminophen level is 0, but they have liver dysfunction, and we'll treat them. And there are some studies out there that point to the effectiveness of that. And what's the deal there? How does it work there? And I don't think anybody really knows. That comes into play as far as maybe having some sort of antioxidant effect. But there are some studies, particularly a couple studies from Britain that show that it does seem to work in late presenters, particularly late presenters with liver dysfunction, even if they have 0 acetaminophen levels. The other scenario that sometimes comes up is acute ingestion time unknown. And this is the same sort of thing where you got to scratch your head and say, well, gee, I'll get the level, I'll look at their LFTs, I'll see if they have GI symptoms or not. But at least in this scenario, sometimes what can come up is, sometimes you may get a family member, a friend come in 5 hours later and say, well, gee, I was actually with this guy, and I know that the farthest back in time that he could have taken these was 3 a.m., so maybe you can then plot something on a nomogram. But if you don't know, we tend to err on the side of treating these people. Special situations, what about people with decreased glutathione stores, for example, patients who are malnourished, cancer patients, HIV patients, chronic alcoholics? They may be more prone to getting acetaminophen toxicity. It's probably a little bit more likely in the sort of chronic ingestion scenario as opposed to acute. And in general, with most cases with acute ingestion, I don't really change what I do in terms of treating them, lowering the line or something like that, although I know in some centers they will do that, but and there probably is some risk, but it's probably more of a problem in the chronic scenario. The other thing is someone's on a P450 inducer, say like phenytoin or phenobarbital. they're in a scenario where when they take acetaminophen, it might be more likely to be metabolized to the toxic NAPG metabolites, so they'd be more prone to developing hepatic dysfunction. Now that, in a quick nutshell, is acetaminophen. Before I switch, let me just see if there's any questions about acetaminophen.
For these borderline kind of patients, where you're kind of deciding, are there like bad side effects of giving NAC?
No, like I said, the main worry would be anaphylactoid. That's really the main, plus, well, the cost of hospitalization and that sort of thing. But again, it appears to be that the IV form is fairly safe. I mean, if you're really worried, you could go with the PO preparation. Okay, let's move on to salicylate. There's terminology, I tend to say aspirin and salicylate in the same breath. Let's just discuss that a minute. Aspirin is acetyl salicylic acid. But when you ingest aspirin, whether it's a therapeutic dose or an overdose, it hydrolyzes fairly rapidly within minutes to salicylic acid or salicylate. So that's really what we measure when we're doing levels in these patients. Methyl salicylate, have any of you heard of oil of wintergreen? Oil of wintergreen is something that I actually bought some not all that long, well, about 8 or 9 years ago at it used to be a drugstore next to the Mall St. Matthews, just because I wanted to add to our show and tell collection at the Poison Center. But it's something that really should not be out there. It has a nice smell to it. It smells like, what do you call it, spearmint, I guess. But it's a very, very concentrated form of salicylate, such that 1 teaspoon, as low as 1 teaspoon, could actually kill a very young child. And the only uses I know are sometimes surgeons will dab it on their mask if they're doing a colon case, and I guess maybe sometimes people use it for baking or making candies or that sort of thing. But it's one of many products that really should not be out there because it's a very, very concentrated form of salicylate. And actually, when I bought the bottle, I had it on my desk here at university for a while. It was full. And I got paranoid. I thought, well, we get these crazy people in the ER. Someone will walk into the office in the evening and open this stuff up. So I emptied it out. But it still has a nice aroma to it if you take a whiff. Now, aspirin toxicity or salicylate toxicity, it's still around. We get quite a few cases of this. It's when acetaminophen came out, as you can guess, the incidence of salicylate toxicity went down, but still we get plenty of salicylate toxicity cases every year in the United States and worldwide. A lot of over-the-counter products have either aspirin or acetaminophen or both, and it can be very confusing because the public may not realize that aspirin or acetaminophen is in these products. And I always get confused, too, because I get these calls and someone will say, well, I got someone with Anacin. Is that aspirin or acetaminophen or both? And things change. The drug makers change the content. But as of about 2 or 3 years ago, this was accurate. So Anacin can contain aspirin or APAP. Excedrin can contain aspirin or APAP or both. Alka-Seltzer I always thought was just aspirin, but apparently it can contain acetaminophen. And then Alka-Seltzer, when you think about it, it's kind of silly because it's something you would take to soothe your stomach, I suppose, but why would you want to take it if the reason for your abdominal discomfort was gastritis or duodenal ulcer? And then Pepto-Bismol contains aspirin. It also contains bismuth. Sometimes people will take it when they're going to certain countries where traveler's diarrhea is a concern, but they're taking it for the bismuth portion, but they may not realize that aspirin is part of Pepto-Bismol, and they may take too much aspirin in the process. How does it work? Inhibits cyclooxygenase, and then cyclooxygenase, or COX, is the one that enables the synthesis of prostaglandins, which mediate fever and inflammation. Pharmacokinetics here, like with acetaminophen, absorption with therapeutic doses is fairly rapid, 30 to 60 minutes. In overdose, peak absorption can be quite far out, 6 hours or longer. And here's one of the 5 or 6 pitfalls where you can get burned as a physician, because some books will say peak is at 6 hours, and I can tell you we've had many a case at our poison center, at our ER, cases I've heard from around the country and I've seen published where it can be much longer than 6 hours. So just beware. It may not be 6 hours, and if you really want to be safe, you may have to get serial levels beyond that to be sure it goes down. Half-life in therapeutic doses is fairly quick, 2 to 4 hours, and here's one where you really can get quite long half-lives in overdose, up to about 20, 24 hours or so. In therapeutic doses, elimination is mainly by conjugation with a little bit of renal elimination, but if you ingest toxic doses of aspirin, then you're going to saturate the conjugation pathways, and then you will have more renal elimination of unchanged salicylate. It's a weak acid. The pKa is 3.5, so at a pH of 3.5, half is ionized, half is unionized. But this brings up the rationale for, in some patients, alkalinizing the urine. If you raise the urine pH, you're going to have more salicylate in the ionized form, and hopefully that will just go out of, or stay outside the body, so to speak. Remember, ionized particles cannot cross over body membranes very easily, so if you can trap it in the urine in an ionized form, it's not going to go back over the kidney into the bloodstream. As a rough guide with an acute toxic dose, less than 150 milligrams per kilogram is generally no problem. And that's one of the little guidelines or protocols we have at the Poison Center. If we have a non-suicidal case, say a pediatric case where it's truly accidental and there's nothing fishy going on, if the dose is less than 150 milligrams per kilogram, we do not send them to an ER or some healthcare facility. If they've taken over 500 milligrams per kilogram, you can expect trouble, and between 150 milligrams per kilogram and 500 milligrams per kilogram is basically in between. Chronic toxicity, again, this is like acetaminophen and many drugs. You can see acute toxicity, you can see chronic toxicity. And chronic toxicity might be a setting where, I don't know, you have an elderly patient with some dementia and they have some joint pain, and over time they take aspirin, they take too much, and they develop toxicity. And this is where you read in the literature or hear about cases where patients were misdiagnosed and aspirin toxicity was not suspected. And as you can imagine, if you have an elderly patient who comes in acidotic, febrile, you look at their urine, it comes back the old 5 to 9 white cells, or you look at a chest x-ray and you say, is that atelectasis, or there's a little bit of infiltrate, you might be tempted to say they're uroseptic or they're pneumonia with sepsis, but just beware, there are cases out there that have salicylate toxicity. As a rough guide, if someone has chronic toxicity like I'm describing, they're likely to be more ill-appearing than someone with acute toxicity with the same level. So someone who's chronic toxicity and their level is 60 milligrams per cent, they're probably going to be pretty sick and may need to be dialyzed, whereas it's an acute overdose and their level is 60 milligrams per cent, they may still look okay and may not need to be dialyzed. This, for example, this is a common scenario with lithium too, where chronic toxicity, they usually look much worse for a given level compared to acute lithium toxicity. How does it work? Well, aspirin or salicylate is kind of a oddball drug. With a lot of drugs in overdose, what you see in overdose is often an extension of the adverse effects that you see in therapeutic doses. So for example, if someone takes diazepam, Valium, 5 milligrams, they might be kind of calm and not anxious and that sort of thing. If they take 500 milligrams of Valium, they're going to be CNS depressed, comatose, perhaps that sort of thing. But with aspirin, you get this whole hodgepodge of effects in overdose, and a lot of times it's kind of surprising or doesn't make sense. But the one thing it does, it stimulates the CNS respiratory center, so that's going to raise your respiratory rate and respiratory depth, and we'll talk about that more in a little bit. It interferes with the Krebs cycle, uncouples oxidative phosphorylation. So one thing you can see is metabolic acidosis, particularly an anion gap metabolic acidosis. Gastric irritation, that's no surprise. Altered capillary integrity, that's probably the explanation for why you can get non-cardiogenic pulmonary edema. You can also get cerebral edema. Non-cardiogenic pulmonary edema, by the way, is felt to be an absolute indication for dialysis, although you really don't see it all that often. And then, of course, you get inhibition of platelet function, but perhaps a lesser-known fact is that, particularly in overdose, you can have inhibition of the vitamin K-dependent clotting factors. But fortunately, you don't really see that much bleeding in aspirin overdose or aspirin toxicity, but you know, there's enough other trouble going on in most cases. So acid-base-wise, you're going to see metabolic acidosis with the compensatory respiratory alkalosis, but then with this additional stimulant effect on the CNS, you may actually see pHs that are normal. I've seen a few slightly above normal, and you're going to see very low PCO2s, so just be aware of that. And there's a I don't know if you ever heard of this. There's a article, I think it was Annals of Internal Medicine or Archives of Internal Medicine from the 1980s, published by some, their names were Narens and Emmett, and they talk about how if you have a compensated metabolic acidosis, let's say from sepsis, and you look at someone's blood gas as a rough guide, the number of the PCO2 should be about the same as the last two numbers of the pH. So you'd expect perhaps the pH might be 7.27 and the PCO2 might be 27 or 28 or something like that. On the other hand, if it's aspirin, it's not going to be like that. You're going to see a very, very low PCO2, and like I say, the pH may be close to normal, or even in rare cases above normal. With compensated metabolic acidosis with sepsis, as you know, the pH is not going to rise to normal. CNS, one of the things that you see with salicylate toxicity, or you can see, is altered mental status. And if someone has altered mental status just from the aspirin, they usually have significant toxicity. And that is, sometimes it's hard to tell. We get these people who took aspirin, they took alcohol, and God knows what else. But if it's just from aspirin and they're confused, they're probably pretty sick, number one, and they probably need to be dialyzed, number two. And this is another one of these points where you could get burned if you don't think about that. Coma can occur, but it's not a usual sort of toxin drug where we think of coma occurring. Same sort of thing with seizures. There are plenty of drugs out there that cause seizures very commonly. It can occur with salicylate, but it's not that common. Metabolic electrolyte disturbances, hyperthermia. This is one of several drugs in overdose where you got to make sure that their temperature is not, say, 108 or something like this. And this is probably more a concern for us in the ER than you guys, but the worst thing that could happen is you get some combative, difficult to deal with patient and triage in the ER, and they're moving around and fighting and swinging. That's exactly the type of patient where you got to get all hands on deck and get a good rectal temperature to make sure that they're not super hot. Diaphoresis, of course, can go along with that. Hypoglycemia can occur with aspirin toxicity, so just remember that. If someone has altered mental status, you would want to get an AccuCheck, and that's something that you can fix very easily. The other thing they talk about with aspirin is that you can have peripheral euglycemia in the setting of CNS hypoglycemia. It's like, well, how are you going to know that unless you do a quick spinal tap? That used to be just based on some animal data, but then a couple of years ago I saw a case report, actually two case reports in one, of a couple patients who had aspirin overdose. They were confused. Their AccuCheck was normal, but they both got D50 and their mental status rapidly improved. So I guess you got to assume that their CNS glucose was perhaps low in the setting of a normal peripheral glucose. Hyperglycemia, it's sort of like, so what? You see that with a lot of overdoses. Hypokalemia, that's another thing. You got to look for hypokalemia in your aspirin overdose cases, and you need to correct it. And the reason you can get hypokalemia, particularly from the vomiting and the effects on the kidney, and the reason it's a problem is if someone's hypokalemic, the way the kidney looks at it, hydrogen ion and potassium ion are similar in size. So if someone's hypokalemic, the kidney will attempt to hang on to potassium at the expense of spitting out hydrogen ion into the urine. So as you can imagine, if it's spitting out hydrogen ion into the urine, it's going to be very difficult to alkalinize the urine. So look for hypokalemia and make sure you treat them, especially if they have significant amount of aspirin on board and you're anticipating alkalinizing the urine or trying to alkalinize the urine. Hypo or hypercalcemia, I've seen that in all the books. I don't know if I've ever seen a case related to aspirin. Hypo or hypernatremia would probably be more likely to occur based on the fluid and electrolyte losses and that sort of thing in the setting of dehydration. Other things that occur clinically, tinnitus is quite common once you get elevated levels of aspirin. You can actually get hearing loss as well, but tinnitus is more common. Again, GI effects are fairly common. Renal effects, although you can get renal toxicity with an aspirin overdose, it's not that common. And that always sort of surprises me because non-steroidal, particularly non-steroidal chronic use, as you well know, it's a very common cause of renal toxicity, but for whatever reason, it's not that common with aspirin. Liver toxicity, you can see, not that common though. Pulmonary toxicity, again, the main thing we're talking about here is non-cardiogenic pulmonary edema. And then the hemostatic effects, as I mentioned earlier, even though you can get inhibition of platelet function and some of the vitamin K-dependent clotting factors, fortunately, it's very, very unusual to see bleeding problems in someone who overdoses on aspirin. So the diagnosis, again, first of all, it's easy to miss. And just to give you an example, if you call our poison center here and you have what you might call a generic overdose of you have no idea. Someone took, say, a bottle of pills, and let's say their exam is normal. What's our friendly poison center going to tell you? Well, obviously watch, observe, see what happens, give them charcoal probably. But we're probably going to tell you get an acetaminophen level in the blood, salicylate level in the blood, and then for what it's worth, some sort of general qualitative urine screen, usually for drugs of abuse, and that's probably the least helpful of the 3 tests we're going to recommend. But the reason for the acetaminophen level, again, I hope is obvious because I just talked to you about that. The salicylate level may not be so obvious, and you might say, well, gee, if someone took a fair amount of aspirin, shouldn't we know that from the physical exam or the blood gas or the chemistries? And yeah, that's right. I mean, if they did take a significant amount, but one thing, just remember this, let's say someone comes in and you have no idea what they took. Let's say it was aspirin, and you might get a salicylate level of, say, 17 milligrams percent, which is 17 milligrams per deciliter, which is a level that's unlikely to cause signs and symptoms. But yet, if that's their level, that's kind of a clue to say, well, I got to repeat that level about 3 or 4 hours out to make sure it's not climbing, because as we talked about, you can get delayed absorption problems. So that's the reason we do that. The other thing that happens too, and this only became clear to me why in the last few years, I've been noticing over the years we have a lot of these cases that come through the poison center. I'd be looking at the charts and you'd see salicylate level 2 milligrams percent, 1.8 milligrams percent. Now I was wondering why that is, and I finally found out from a PhD lab friend of mine. Apparently certainly there are patients who are out there on 81 milligrams of aspirin, low-dose aspirin, but there are also dietary sources of salicylate out there. That's probably the reason in a lot of cases. So that's another thing to consider when you get a level that's not stone cold zero. Therapeutic salicylate levels, we never really get levels when we're treating patients with salicylate. I don't know, I heard rumors sometimes maybe pediatricians do it in patients with juvenile rheumatoid arthritis. I don't know if you med-peds people, maybe shout out if that's true or not, but they do say that therapeutic salicylate levels are somewhere in the range of 15 to 25 milligrams percent. But toxic levels, what's a toxic level? Well, like I mentioned earlier, it really depends on whether it's an acute overdose or a chronic overdose. And as a rough guide, if someone has hit 60 and it's a chronic overdose, they're probably needing dialysis and probably quite sick. If they've reached about 90 or 100, they're probably, and it's an acute overdose, they're probably going to need dialysis and look quite sick. Timing levels, I think we touched on most of that. Beware of the late rise. But the other thing you might say is, and I guess this is more for us in the ER, but if we have someone come in the ER and we know they took aspirin, and we're saying, oh gee, we want to get a level 6 hours and maybe even farther out than that, and that's a long time because then the patient's got to sit here for several hours and we got to wait for the lab to come back. Can't we get a level a little bit sooner than that and go by that? And I think as a rough guide, yeah, you probably could get a level that's, say, 3 or 4 hours post-ingestion. And if it came back 0, I think you'd probably, or very low, you'd probably be home free. But again, just remember, watch out for those late rises. There's something out there called a Doan nomogram, which fortunately is not appearing in the textbooks that much anymore, but you will see it occasionally. It's sort of like this Rumac acetaminophen nomogram. You plot time versus level, but there are a lot of problems with the Doan nomogram for aspirin, and without going into the details of it, I would tell you just don't use it. It's a problem, and it's really not appearing that much in textbooks anymore. Lab confusion. Here's another reason you can get burned. When we think about salicylate levels here in the United States, we're always thinking in terms of milligrams per deciliter, which, remember, milligrams per deciliter is milligrams per 100 cc's. It's also milligrams percent. However, there are some labs that still, for whatever reason, report salicylate levels in milligrams per liter. And I know a few years back we had a patient who was transferred from, I think, Flagey in Bardstown with a salicylate level of 130, and they show up, and as it turns out, that was 130 milligrams per liter, so 13 milligrams per deciliter. They did not need to make the 45-mile ride from Bardstown to here. So that's another reason you could get confused with aspirin. I know when I was a resident, too, I was a resident at UCLA, we had someone that came in and the level was 170, and I thought, oh my God, the patient looked great, and I thought, oh my God, this is terrible, but it was the same sort of thing. Gastric decontamination. This is one thing we really didn't talk all that much about, acetaminophen or aspirin. I probably should have, but activated charcoal you would probably give to, in most cases of, at least early on, with aspirin or acetaminophen overdose. And there's always the question how far out, and that's sort of a long discussion. But the one thing I'll say with aspirin is aspirin tends to sit in the stomach, and that's the reason you can have the delayed rise in levels. Remember, the absorption occurs in the small intestine, not really in the stomach. So with aspirin, I'd be tempted to decontaminate them several hours out, whatever that means. And this is one of the relatively few drugs, too, where I might be tempted to not only give them charcoal, but also lavage their stomach as well, just knowing that it can sit in the stomach. It's such a bad toxin. Why not go for it and really try and make sure it does not go down into the small intestine and become absorbed. Other treatments, forced diuresis. Some of the older books would say, oh, gee, just really give them fluid to beat the band. Nowadays, the feeling is that's really a no-no. Certainly, a lot of these patients are going to be dehydrated, and if they are, you fill up the tank, so to speak, but don't go overboard. Again, remember that they may be prone to pulmonary edema or cerebral edema. And then acetazolamide is a drug which can be used to alkalinize the urine, but unfortunately at the expense of acidifying the serum, and for that reason, you don't want to use acetazolamide. And in general, when we talk about treating the salicylate toxicity patient from an acid-base standpoint, we always say that if they die, ultimately they're going to die a CNS-mediated death, so to speak. And the whole goal really is, from an acid-base standpoint, is to get the drug out of the CSF into the blood and then out of the blood into the urine. And the whole goal there and the whole thing you'd want to do there is hopefully alkalinize the serum and then alkalinize the urine with sodium bicarbonate and hopefully make that occur. Again, hypokalemia, watch for it and treat it, or you're not going to be able to alkalinize the urine. What's the indication for sodium bicarb or alkalinization of the urine? As a rough guide, if someone's symptomatic, number one, or if their level is in the mid-30s or higher, we tend to say administer sodium bicarbonate. And when you're doing that, you've got to be careful. You don't want to raise the serum pH too much. You're probably safe up to 7.50, even maybe just a touch above that, but don't go much above 7.52, 7.53, something like that. And when you look at the urine, you're shooting for a urine pH of about 7.5 to 8. And as far as administering it, there's a lot of different ways you can do it. One, I think I have it in the handout, each amp of sodium bicarb, the typical amp has 44 milliequivalents of sodium bicarb, so you could give 2 amps in a liter D5 or 1 amp in D5 half, something like that. Now, hemodialysis, who needs to be dialyzed? Again, it depends. Roughly 60, somewhere in that land if it's chronic, 100 if it's acute, but don't go by the level alone. I've heard of cases where people really stuck to those levels that they saw in the book. Look at the patient, too. Significant acid-base disturbance. If someone comes in and their serum bicarb is a little bit low at 21 or something, and the pH is 7.35 and the PCO2 is 30 or something like that, you probably want to start with the bicarb. But on the other hand, if someone comes in with a serum bicarb of 10 or 11, you're going to want to see what their salicylate level is too, but they're probably going to need to be dialyzed. Pulmonary edema needs to be dialyzed. If someone's so sick from the aspirin overdose that their vital signs are deteriorating, they're going to need to be dialyzed. Unfortunately, it's not so easy to do dialysis in someone who's hypotensive. Then altered mental status. If you really think the altered mental status is just from the salicylate, they probably should be dialyzed. So here's my summary of the pitfalls. Levels may peak more than 6 hours out. Look at the patient, not just the level, particularly when considering dialysis. Altered mental status, usually need dialysis. Lab confusion in terms of milligrams percent versus milligram per liter. And then chronic toxicity may be difficult to diagnose. You may think it's sepsis or something like that. And here's just 2 examples of cases that I saw go sour, and I think this was 15 or 20 years ago at this hospital. One was a case, and I don't know the exact details, but one was a case of someone who came with an overdose late in the evening. Their level was in the mid-30s. I think they had tinnitus, and maybe their bicarb was a tad bit low, but it didn't really look all that sick. They got admitted, and then the next morning someone checked on them, and all of a sudden they're moribund. They get a level, it's in the 70s, they start dialysis, the patient dies while they're doing dialysis. And I guess the lesson there is just remember the levels may rise even after 6 hours. And then, when you're looking at these patients and doing serial levels, when you do the serial levels, you'd probably want to do the serial levels, say, every 3 or 4 hours out. Plus, you want to have some concomitant measure of what their acid-base status is. And the easy way to do that is with your BMP, basic metabolic panel. Look at the bicarb, look at the anion gap. You might say, well, what about a blood gas? That's fine. And if someone's really sick, they need a blood gas. But, I don't know. I've never had a blood gas done on myself in my life. I've had certainly plenty of venous sticks, but I'd much rather have a venous stick done on myself than an arterial blood gas. So if someone's not that sick, the BMP is a great way for looking at the acid-base status. And then another case I just vaguely remember was someone who took aspirin, and this is again many, many years ago, and they were altered mental status, tachycardic in the 130s, hyperventilating, and their level was around 70. And for whatever reason, the nephrologist didn't want to dialyze because they thought, well, a level of 70, it's not that high, and that's a patient who expired. So again, not just the level, look at the patient. And in any case, I'll stop here. Again, aspirin is just a disaster. There's so many different bad things that can happen.